Hi there. Today we're going to look at immunoproliferative disorders, chapter 18. And I think that as we're getting further and further along in the semester, this starts to get, to me, more interesting. We're starting to look at all the pieces of everything we've put together. Today we're going to look a little bit at some of the laboratory testing we've already done. You're going to see a component of hematology in here, and you may not have covered this yet, but I know that you will have covered some of it when you do hematology, but we're going to take a look at it, but it's starting to bring pieces of the puzzle together, and to me those are the most interesting parts of what we do. In this chapter, we're going to have an introduction to look at several different malignancies associated with the immune system and the evaluation lab testing that we use to help diagnose the patients. This is just the chapter overview, and I think you can read along and see where we're going. This is just a nice roadmap of exactly where we're headed for the day. Immunoproliferative diseases can be broadly classified, I was going to say categorized, as immunologic disorders that are diseases or conditions of primary cells of the immune system or by excess production of immunoglobulins. And in this chapter, we're going to focus on malignancy of lymphoid cell lines. We're going to be specifically looking at a couple of things. We're going to be looking at leukemias, lymphomas, and plasma cell dyscrasias. Leukemias and lymphomas are both forms of blood cancer, but are classified based on where the malignancy develops. When we're speaking of leukemias, we're talking about malignant cells of the bone marrow and the peripheral blood. And we'll see that leukemias can be further differentiated and classified based on their progenitor cell type. That is, are they, do they come from the myelogenous common precursor or the lymphoid common precursor? And of course, the myeloid we know and will review today develops into a number of different end cells that we're not really going to cover other than just in the broadest terms today. As I said, we're going to focus on lymphoid today. Lymphomas, on the other hand, are malignant cells that arise or form from lymphoid tissues, things that we know, lymph nodes, tonsils, spleens, things like that, instead of the bone marrow. So they arise from those lymphoid tissues. And then plasma cell dyscrasias, and another word for dyscrasia is just a condition or disease. Plasma cell dyscrasias are malignant or pre-malignant conditions of plasma cells that can involve, the bone marrow. It can involve some of the primary or secondary lymphoid tissues, and even some non-lymphoid tissues, as we're going to see today. Plasma cell dyscrasias are not leukemias or lymphomas, but are really an immunoproliferative disease unto themselves. We're going to see that there can be really an overlap between the sites in the body affected by leukemias and lymphomas as we move through the chapter today. Malignancies in general are classified and characterized by a couple of different categories of information. In this case, hematologic review of immunoproliferative disorders, we're really looking at, how about the cell accumulation that occurs with the malignancy, and was the cell accumulation caused by one of several different routes? The first could have been, and we talked about this last week when we talked about tumor analysis, tumor immunology. We talked about the fact that there can be failed regulatory controls, and those regulatory controls can either, if they are failed, they can either cause that really rapid proliferation of a cell line, or it can result in a failure of apoptosis, or the predetermined cell death. But the second way that we can have cells accumulate is really have some mutations within the cell that will result in replications of cells that we say are of an arrested maturation stage. So they're generally young, and they're atypical. Morphologically, they're going to look atypical, and there may be some functional changes. So there can be, we're going to see some of them today have very atypical structures, and others look pretty normal, but what they produce is quite abnormal. So let's take a look at further about the malignant cells. I know this slide should look very familiar to you. This was, I believe, I literally took it from the chapter 17, so it would look really familiar to you. In chapter 17, Tumor Immunology, we reviewed the concept of malignant transformation, really that the idea that this is a lifetime effect of having been exposed to environmental factors, and that, there are changes in a couple of different genes involved in normal cell growth. And we specifically spoke about proto-oncogenes and the tumor suppressor genes. Proto-oncogenes are the genes of normal cell growth and proliferation, and tumor suppression genes are the ones that result in changes in the cell characteristics, including uncontrolled or unfettered cell division. I'm not going to spend the time to look over this slide again, but return to chapter 17, review this concept again if you have any questions at all. And I made a note to myself, this is on page 307 and 308 of the textbook. Let me just see, I'm pulling that. Yes, 307 and 308 of this chapter as well. It briefly discusses this process. So you have a couple of different resources to look at around this, but you should be familiar with this. And then we're going to relate these concepts to some of the hematologic malignancies that we're going to discuss today. We spoke again over the last couple of weeks about some of the genetic changes that can occur when tumor-specific antigens, those TSAs, that get coded, they can be mutated by a number of things. They can be mutated by viral oncogenes. If you remember, we talked about Epstein-Barr, we talked about hepatitis B virus, hepatitis C, human papilloma, and HTLV1. So we can have those genetic changes occur as a result post-viral, but if you remember, we also have the capacity for them to be genetically mutated by the host's own proto-oncogenes mutations of the host's proto-oncogenes, or tumor suppressor genes. So remember, we could have the mutation of the host's, a couple of the different hosts' genes, regulatory genes, both of which would end up in these genetic alterations that foster malignancy in the host. And again, just as a sheer point of reference and review, a super quick review, those genetic alterations that come from, the mutated viral oncogenes, or the genetically mutated proto-oncogenes, or tumor suppressor genes, can result in things like single point changes in nucleotide bases, duplications of genes, deletions of genes, and we spent some time looking at translocations of genes, and we gave the example last week of Philadelphia chromosome, but we're going to start to be broadening this conversation into different kinds of lymphoma. Acute promyelocytic leukemia and other diseases are all caused by chromosomal translocations. We're going to look at a video in just a second in which I found this video by chance not that long ago, and it was a really terrific, quick 3 or 4 minute video that gives you a really good sense of how to remember what some of the translocations mean relative to some of these immunoproliferative diseases. I'm going to show this to you, but he's going to mention in there, for example, that translocations on chromosomes 14 are generally a lymphoma based, and other translocations are generally a leukemia. So let me just duck out of that and go to, I have it all queued up here. Give me 1 second just to get situated. Believe it or not, this is a high-tech wonder here, doing this with this video. So let me do this.
So today, let's talk about chromosomal translocations. We'll commonly see these in lymphomas and leukemias. We're going to start with the general rule, and that's that the chromosome 14, if you see that as part of the translocation, it's probably a lymphoma. The IgG heavy chain, the gene for this, is located on chromosome 14. And anything, when you have a translocation, if it's put on chromosome 14, it's likely to be overexpressed. So let's start with Burkitt lymphoma. Notice that I emphasized that the B looks like an 814 for Burkitt lymphoma. And one of the places you'll see it is there's an endemic form in African children. So hence I'm drawing this African child with a characteristic jaw lesion singing into a mic. And that's because we have C mic overexpression, singing microphone, C mic. Now I drew an 8 on the jersey, and I added a few lines on the abdomen and pelvis because that's where you'll see lesions in the sporadic form of this disease. Now moving on to a translocation of 1114. This you'll see in mantle cell lymphoma. So the obvious, let's draw a fireplace with a mantle. We'll use the 2 ones out of the 11 to hold up the mantle. We'll draw fire, real 1, and on the mantle we're drawing an old-time bicycle next to T1, Division 1 bicycling. And really what we're talking about is cyclin Z1 gets overexpressed in this lymphoma. The next lymphoma we're going to talk about has a translocation of T1418. So this is actually a follicular lymphoma. So let's actually make a small shaving commercial. The 1 and 8 look like a hair coming out of a hair follicle, right? You know those shaving commercials where they go real up close? And here's a razor blade with 2 razor blades, easy to hold grip, and with the letters BCL2. And BCL stands for blades cut long hair. That's how you can remember follicular lymphoma. Now, those are the lymphomas that are super high yield that you're going to have to know about. Let's talk about the leukemias. If it doesn't have a 14 in it, it might be a leukemia. Simple as that. So first, let's talk about CML. Now, Sketchy Path had a great way of memorizing this, so I'm going to borrow a little bit from them. Let's draw a Liberty Bell, broken, which is located in Philadelphia. The clock face on our grandfather clock says 922, and there's a camel on top for camel brand. Now, the Liberty Bell is broken, breakable bell, right? BCR able. 922 is a translocation, the Philadelphia chromosome, and CML sounds like camel, hence the camel on top. Next, we're going to talk about the other leukemia that we need to know about. 1517 is a translocation. This is APL, acute promyelocytic leukemia. So we have this guy with his weird sunglasses, 1517, working on his Apple computer, APL. And the reason we're including the glasses is because it responds well to retinoic acid or vitamin A, which is also needed for eyesight. The 922 translocation is also seen rarely in ALL. And in ALL, a translocation of 1221 indicates a good prognosis. I didn't draw a picture for this, just remember that it's very symmetrical. 1, 2, 2, 1. And that's all for today.
So I certainly am not suggesting that you need to memorize everything that he covered there. not by any stretch of the imagination. I think it's interesting that, there are a couple of the translocations that you need to try and remember. You need to try and remember the translocations. You'll see them as we're coming up, some of the translocations of the lymphomas. And obviously we know about CML, but APL, acute promyelocytic leukemia. We're not going to cover that today, but in your lifetime, you're probably going to have to know that translocation. And that's going to be one of the things that maybe will help you to remember it over time. This may or may not help. I thought it was a great little video for this. A couple of points of note. See, Mike, you'll see in the textbook. We're not going to talk an awful lot about it today, but it is a specific genetic marker, so we're going to see that. He spoke of mantle cell lymphoma. That's a non-Hodgkin's lymphoma, as is follicular. So we're going to talk about those two a little bit later, but when he's talking about mantle cell and follicular, he's talking about two versions of a non-Hodgkin's lymphoma. So I guess that brings us to participation question number 1. What is the disease? This question doesn't even make sense. It should say, what disease is the translocation T1114 associated with? The disease is a form of follicular lymphoma. And so it's a form of non-Hodgkin's lymphoma. We just saw that. So moving on, I am guessing that WHO classification of hematologic malignancies is not new to you, or you'll be doing it in the very near future. But I'm just going to briefly touch on the World Health Organization classification of malignancies. So, over the years, there's been numerous attempts to classify hematologic malignancies, including, they tried them with morphologic, they tried it with the French, American, and British consensus classifications, the FAB classification. And most recently, we have the revised European American lymphoma, the real classification for leukemias and lymphomas. And real was the one that was finally adopted most recently by the World Health Organization in 2001, 2008, and though your book doesn't mention it, I think your book was probably published right around the time. It was published in 2017, so that it may have already gone to press by the time that WHO had updated the real to include in 2016. And the system itself, the real system, classifies malignancies based on really 12 major groupings and multiple subgroupings. It's really rapidly evolving. The classification gets changed pretty rapidly, rapidly in the world of science. But I think that and I've definitely seen some subcategories changed more recently than 2016 even. But it's really based on the fact that, the more we find out, the more we're doing with molecular, genetic identification, our methodology is improving, that our classification is getting better. But as it stands today, the classification is really based on a couple of key points. Cell lineage, is it lymphocytic or myelocytic or myeloid? Remember, the myeloid common precursor leads to what? Granulocytes, including neutrophils, eosinophils, and basophils. And myeloid also will ultimately, the common myeloid precursor we're going to see in a minute, we're going to remember that it leads to erythrocytes, megakaryocytes, and monocytes as well. Also, we're going to look at the lineage, the lymphocytic lineage, which is where we're focusing today. The real system also reviews immunologic markers, the CD-based markers, some of the genetic features that we're discovering. And also, we don't abandon morphologic and cytochemical staining in our classification. It's ongoing. So this should look super familiar to you. This was from your textbook. I can't remember what chapter, maybe even chapter 1, so maybe it's not super specific anymore. It wasn't necessarily my favorite version of this, but this was one in your textbook, so I went back to it instead of going out and pulling up another one. But if you go back to chapter 1, you'll see that I actually had a couple of versions of this that I preferred. But leukemias, as I said, are classified based on the originating cell lineage. So that's either coming from the common lymphoid precursor or the common myeloid precursor. Both come from what? The hematopoietic stem cell, right? Hematopoietic stem cell is the source of all of the cell lines. Under the influence of CSFs, they are developed into one of two common precursors, the lymphoid or the myeloid precursor. And the lymphoid precursor is what we're going to develop into, they're going to leave, they're going to the thymus, and the secondary lymph tissues, and we're going to see them develop into either T cells, natural killer cells, or B cells, and secondarily, though we're not talking about them today, dendritic cells. The HSC develops into the common myeloid precursor, and again, we're not going to worry about dendritic cells today. We're not doing that. We're talking about monocytic neutrophils, eosinophils, basophils, erythrocytes, and megakaryocytic cell line or the platelet cell line. Leukemia, so that's the first classification. That's the kind of rough cut classification. What's the cell line? The second cut that we make is really kind of based on the factors related to the onset of disease, and so they're classified as either chronic or acute. And there are some general statements we can say about chronic and acute malignancies. These are not hard and fast rules. So there can be variants to this, but this is a fairly decent assumption that you can make about chronic and acute leukemias. So chronic refers to malignancies or leukemias or lymphomas that have a slow onset. They come on, they're kind of, you don't notice that it's happening until the disease is fairly well progressed, unless you happen to have just caught it by chance at some, at a routine visit. You frequently don't know that it's happening because it's kind of a slow growth. It just moves along. In fact, some of them can be so slow moving that you have a very good, fairly decent lifespan that's associated with it before it may transform into something else. Chronic diseases tend to affect older individuals, and as I said, longer survival, but unfortunately, they're less responsive to treatment. Again, very general statements. Acute diseases are normally associated with a rapid onset, tend to be somewhat younger individuals, children to young adults. We tend to see those blasts and precursor cells in acute diseases. The bone marrow is is producing and tossing out predominantly very young cells. Again, it's I said rapid onset. It's also a rapid progression from, if it's left untreated, it can be rapidly fatal. So it's got a rapid progression of the disease, which is bad, but the good news is it tends to have a higher response rate to treatment. So that's a good news. And rapid growth of leukemic cells can suppress other cell lines. And that actually can take place in chronic diseases too, although you get a little bit more, what am I trying to say? Compensation when you are developing it slowly. But those are generalities about this. So first cut is the cell lineage. The second cut is how is the disease progressing. So where are we going for that's the general stuff. Where are we going today? We're going to look at leukemias, lymphomas, and plasma cell dyscrasias of the lymphoid cell line, and we're just going to look at a select group of them. There are certainly more of these, and they get subcut into many different versions of these. But let's look at just a couple of them. The first one we're going to look at is acute lymphocytic leukemia, or ALL. Acute lymphocytic leukemia is characterized by poorly differentiated lymphoid precursor cells, aka blasts, in the bone marrow, and we see them in the peripheral blood. The development of this rapid onset of these precursor cells ends up in the bone marrow, proliferating so quickly that it forces the other cell lines to reduce their cell production, kind of forces out these other cells from the bone marrow. So patients end up with a fairly high degree of anemia and thrombocytopenia. They're going to have neutropenia. They're going to have really a suppression of other cell lines, except for these abnormal lymphoid cells, these lymphoid precursor cells. We also see that patients in this case have swelling of the liver and spleen, hepatosplenomegaly, so enlarged livers and spleens. And we generally see ALL, acute lymphocytic leukemia, in young children aged 2 to 5. Sad news. Good news, it has a very high remission rate, 90% remission and an 80% cure rate. So it's highly responsive to treatment. Conversely, though, if an adult is diagnosed with ALL, it tends to have a much more poor prognosis, unfortunately. There are 4 types of acute lymphocytic leukemias, and actually you can see these really, insanely, hematologists could love looking at these blast cells, but this picture was a beautiful photograph of perfect blast cells of ALL. So there are 4 different types of acute lymphocytic leukemias, and we're going to classify them as either pre-B cell ALL. So it's either a pre-B cell acute lymphocytic leukemia that expresses what we talked about before. It expresses what is termed the common acute lymphoblastic leukemia, or a CALA form. And what that is those are, CALA is the associated antigen is CD10. So when we talk about CALA, I'm not sure I said the word antigen at the end in that. So CALLA, common acute lymphoblastic leukemia associated antigen. The antigen is CD10. It's the most common of all ALLs. It has a very clear genetic marker that you see here, TEL-AML1, and the translocation that we expect to see is chromosome 1221. And CALA ALL is associated with hyperploidy, or what's that mean to you? I hope that you're saying that you think it means there's hyperploidy, hyperdiploidy, is more than 46 chromosomes. And when you do, that has a good prognosis. Hypodiploidy, it has a poorer prognosis. So that's kind of the crosscut there. We also have several other less common acute lymphocytic leukemias that we're not going to really spend a lot of time on because they're far less common. We have pre-B cell ALL without CALA, so it's not CD10 positive. We have T-cell ALL, and then we have a very rare mature B-cell acute leukemia, but again, pretty rare. I think that the bulk, when you're diagnosing them in the lab, the bulk of the ALLs that you're going to see are of this type. Chronic lymphocytic leukemia, you can see in the picture here, is the most common leukemia in adults. You see this with a fairly high degree of regularity. Like many of the immunohematologic disorders that we're going to see today, it tends to affect men more than women. In this case, a 2-to-1 male to female ratio. And it's characterized by lymphadenopathy and hepatosplenomegaly. We're going to see some other typical findings of CLL, which is an increased absolute and relative lymphocyte count. So we know that it's increased percent as well as absolute lymph counts. And we tend to see normal red cells and platelets. But what we also see are these smudge cells, these fragile white blood cells that when we make the smear, they break into pieces and they're destroyed in the smear making process. So smudge cells tend to give you, when you see this many lymphs, this many mature lymphs on a blood smear, you don't really need the smudge cells to see where you're going with this, but it doesn't hurt. Chronic CLL is almost always of B-cell origin, and it will be positive for CD19 and unusually weakly expresses CD20, whereas typical mature lymphocytes, I believe, will express CD20 much stronger. And again, this is going to develop, we're going to see these small, the perfectly sized mature lymphocytes, and they look normal. This is one of those cases where I said at the beginning that they can have a nice normal morphologic appearance, but be dysfunctional. This is one of those cases. We're going to see cases as we move through today that cells are not normal looking. But in this case, that looks like a perfectly normal lymphocyte, and you wouldn't know that there was anything to it if there wasn't, 100 others in the same field. And obviously, we're going to see the findings of an elevated white blood cell count. You can see in this one field, there are no neutrophils at all. I'm looking, it's tough to tell from this vantage point. I don't see a lot of platelets either, to tell you the truth. It doesn't really look like a normal platelet count on this one. This is obviously a very thick area of the slide, but that can happen when you have this many white cells. So it's very difficult to find an area that's not sort of overlapping. That's what we're going to say about CLL. Again, this is just a quick overview. We're not going to spend a lot of time on any of these. These are a broad overview of immunoproliferative disorders. Hairy cell leukemia is another lymphoid-based leukemia. It's rare, but it's very distinct in its appearance. This is one, again, more male to females. This is a chronic disease, so it's got an adult onset. It's typically seen with an adult onset. And this is also seen, particularly this has a pancytopenia. So that should be in red. What does that mean to us? It means that all the other cell lines are fairly well depressed. So the patient's going to be anemic. The patient is going to have a neutropenia, and the patient is going to have a thrombocytopenia. The hairy cell leukemia is known for the fact that it infiltrates the bone marrow and the spleen, but in both cases without any node involvement. So you're not going to find any of these hairy cells out in the lymph nodes, which is unusual. These malignant lymphocytes have this really, they're known for this sort of, you don't see a cytoplasmic membrane, and you see these little hairy projections off of the lymph. You might, if you didn't know better, look at it and say that they were, something wrong with the dead lymph or something. Look at that, it has no cytoplasmic membrane. But look at that nucleus, that is spectacularly intact. And it makes you think that there's no sense that that's a dead nucleus. They're very large. If you look at them, look at the nuclear size. So here's a normal red cell, and this nucleus is much larger than a typical, here's the size of the red cell here. Remember, nucleus of a lymph is generally about the size of a normal red cell. So this is an oval nucleus that still has a very high nuclear to cytoplasmic ratio. Hairy cell leukemia is a B cell neoplasm, so these are technically mature B cells. They're going to be positive for the same CD19, CD20. It's going to also be positive for CD22, but unlike normal cells, they are going to have a CD positive. It's going to be positive for CD103 and CD123, and we're going to see if one of the lymphocytes are positive for CD103. It's very highly specific for hairy cell leukemia, so we'd have to say that this was one of our substantive clinical findings in the laboratory for the diagnosis of hairy cell. And we are going to see when you're staining for CD123, it's not so much the presence of CD123, but it's that it's an unusually bright staining of CD123 that's characteristic for hairy cell leukemia. As I said, these are mutated B cells, and the gene associated specifically with it, this is more for information, I can't imagine I would ever ask this, is the RAF V600E gene. Again, this is a pretty rare disease, although it depends on where you work. You know, at my lab, we had probably, I don't know. I mean, in my career there, we probably had 6 or 7, maybe more, hairy cell leukemias that came through and were diagnosed in the lab. So when it's, you know, when they talk about rarity, I think it depends on where you work. If you work someplace with a large hem-onc population, it's not that rare. Okay, so identification of CD10 markers that are associated with which type of leukemia. If we go back, we think of they were associated with CALA, C-A-L-L-A, CALA, acute lymphocytic leukemia. So that's CD10 markers were associated with CALA. So now we're going to just move into lymphomas. We're just going to kind of keep moving along here. Lymphomas are, we're going to break lymphomas down into a couple of different categories. And if we go back, I should have put this back on the slide deck so that we could see where we were headed again. Here. Nope, I didn't put it. Well, there you go. We're going to look at Hodgkin's versus non-Hodgkin's lymphomas. So after I just am giving you all like vertigo going through this so quickly. So first we're going to look at Hodgkin's lymphoma, or HL. The characteristics we expect to see in patients with Hodgkin's lymphoma is adult onset, anywhere from 20, maybe 30 years old, up to kind of 55. Patients that are identified as having Hodgkin's tend to have may have a family history of it. Sort of, I don't want to say predisposition to it, but it is, if you have a family history of lymphoma, we see patients that develop Hodgkin's lymphoma frequently have some family history that we call it a family cluster. So maybe you have that. Being male is another one of those things that you know, sort of gives you a higher likelihood of developing this. And we see patients that, again, you know, causation versus, you know, commonality, you know, who knows, but we do see it in patients that at one point had Epstein-Barr infections. We see a higher proportion of those patients develop Hodgkin's lymphoma. So the association is made empirically from that. Let's see, what else do we want to talk about? Hodgkin's lymphoma develops in the lymphatic system, spreads to the lymph nodes and other organs. As it, you know, it doesn't have to spread, you know, systemically, but it will maybe, you know, to the spleen, to the liver, to So it can spread beyond the lymph nodes, I guess is what I'm saying. Staging of Hodgkin's lymphoma is classified in one of 4 ways, and this is going to really end up driving our diagnosis. Stage 1 is the cancer is limited to one lymph node or a single organ. Stage 2 is the cancer is in 2 different lymph node regions of the body, or the cancer has invaded one organ and some nearby nodes. So really it's an involvement of 2 separate things. But what stage 2 is if all of the invasion is above or below the diaphragm, it's still staged as 2. When cancer moves into areas of the body both above and below the diaphragm, it's considered stage 3, and stage 4, cancer cells are in several portions of organs and tissues, throughout the body, lymph nodes, liver, lungs, and bones. So Hodgkin's lymphoma, we look at that. We're going to look at 2 different classifications of Hodgkin's lymphoma, the classic Hodgkin's lymphoma, or the nodular lymphocytic predominant Hodgkin's lymphoma, NLPHL. So the classic, actually, you know what? This right here should have been at the top. I apologize. I don't know how I did that. This should be at the top. We're going to look at 2 classifications, and we're going to develop into this. So this was all related to Hodgkin's lymphoma. So we're going to look at 2. We're going to look at classic Hodgkin's lymphoma, or HL, and then the NLPHL. So that classic Hodgkin's lymphoma that we just talked about, adult onset, the family cluster, being male, the post-Epstein-Barr, there are 4 subtypes of that classic form of Hodgkin's. Included among that is the most common is the nodular sclerosis cell type. In that, we also have some with it's called mixed cellularity. We have some that it's called lymphocyte rich and then lymphocyte depleted. And so that is what you would imagine they would be. We're going to focus on the nodular sclerosis because that's the most common. In the nodular sclerosis, as well as others, we can see what are called both Hodgkin's and Reed-Sternberg, or RS cells. Reed-Sternberg cells are like the classic appearance that people look for in Hodgkin's lymphoma. We see them in the lymph nodes and other lymphoid organs. And with this yellow arrow here, this is a typical Reed-Sternberg cell. And what classifies a cell as a Reed-Sternberg is they are morphologically different than other lymphoid cells. You can see that clearly. They take on this appearance. They call it an owl appearance. The cell is in appearance, they're big. You can see how comparatively large they are compared to other cells. So they're comparatively large. They are bilobed. So here's one lobe, and here's 2 lobes of this lymphoid cell. And they have 2 prominent nuclei. So we have bilobed, and each of them have a nucleolus in them, or nucleoli. And the nucleoli it takes on an appearance. If you look at it, it looks kind of like an owl, like an owl's eyes. And so we say that if someone says the cell had an owl eye-like appearance, your mind should automatically go to Reed-Sternberg cells. I don't have a picture of them here, but the second cells that we see in classic HL are called Hodgkin cells. They resemble the Reed-Sternberg cells in a great number of ways, but they're still large. But the nuclei are not bilobed, and they have a single nucleoli in them. So they're still a very large cell, but they don't take on this kind of classic appearance. Reed-Sternberg cells have an interesting functionality to them that you wouldn't expect. They're B cells, so this is a B cell lymphoma. We can see here it's a B cell lineage. So though they're B cells, Reed-Sternberg cells possess immunologically mutated heavy and light chains, but they still interact with the immune cells, like CD4, CD8, T cells, B cells, plasma cells, etc., through the release of chemokines and cytokines that allow the Reed-Sternberg cells to interact with normal cells of the immune system. In fact, the chemokines released result in a significant number of immunologically normal cells to go to the site of the tumor. And in fact, a tumor that's associated with Hodgkin's, I think, 80 or 90% of it is actually immunologically normal cells. They're not these Hodgkin's or Reed-Sternberg cells. They're immunologically normal, and it's under the actions of these chemokines and cytokines from the Reed-Sternberg cells. So it's kind of a weird interplay that they do, which I think is very strange, that you wouldn't expect in a tumor condition. Finally, as I said, they're B cell lineage with the typical B cell marker of CD20 is weak or absent. And they're also positive, though, for CD30 and generally positive for CD15. So those are some of the classifications. When I say they're positive for CD30, they're universally positive. So the Hodgkin's and Reed-Sternberg cells are universally positive for CD30, 100%. And generally, to a lesser extent, CD15 positive. So those are some of the classic signs of someone having a Hodgkin's lymphoma, a classic Hodgkin's lymphoma. We can have, as I said, there's another type. There were the two types of Hodgkin's lymphomas. There is the nodular lymphocytic predominant Hodgkin's lymphoma, or the not any easier to roll off your tongue, NLPHL lymphoma. This is a much rarer type of Hodgkin's lymphoma. It involves, again, large abnormal cells. This is a nodular lymphocytic predominant Hodgkin's lymphoma cell. Right here, you can see comparatively, it's still very, very large, but it doesn't have the same appearance that we see in the classic version. The cells of NLPHL are said to have, the Reed-Sternberg cells are said to have a popcorn appearance. So if you look at, to kind of use your imagination, but there's the pops of a popcorn. So they're said to have a popcorn appearance. These Reed-Sternberg cells, this is a version of Reed-Sternberg cell, we call it an NLPHL cell, are lymphocytic. Sometimes they call them histiolytic cells, but they are, whatever you call them, they have this popcorn-like appearance, and that's a classic, I shouldn't use the word classic, that's a characteristic of nodular lymphocytic Hodgkin's. This also is a B cell lineage and expresses both CD19 and CD20. If you remember, the classic had a weak expression of CD20, so this has a stronger expression of CD20. And unlike, comparatively, to the classic, the nodular lymphocytic predominant Hodgkin's lymphoma rarely expresses CD15 or CD30. And if you look back here, Hodgkin's classic is positive. Remember, we said universally positive for CD30. So we can see how we can use flow cytometry and immunophenotyping to really work not just off the morphologic changes that are quite apparent in the two different diseases, but that we can really look at this at a micro level by looking at the antigenic markers on each cell type. So those are the Hodgkin's lymphomas. Next, we're going to look at the non-Hodgkin's lymphomas. And so we're going to call those the NHLs, the non-Hodgkin lymphomas. And non-Hodgkin's that's hard to say 3 times fast. Non-Hodgkin lymphomas, sometimes, well, no, never mind. I'm not going to say that. Is a cancer that starts in the white cells, the lymphocytes, and it is, again, just like we expected. It's an immunoproliferative disorder, so lymphocytes just grow out of control. They are a heterogeneous group of neoplasms, and most of them are clearly of B-cell origin. They have, we're going to be able to identify immunoglobulins on the cell surface, making it can't be anything other than a B cell. We're also going to see some CD19 or CD20 positive immunophenotyping. We're also going to see that the malignancy of this is caused by gene rearrangement. So in this case, in non-Hodgkin's lymphoma, they know what the genetic mutation is. It's a rearranged immunoglobulin gene. There are a number of different kinds of non-Hodgkin's lymphoma, and we're not going to look at all of these today, but you should kind of be familiar with them. So we heard earlier about the follicular and the mantle type, which we said were both non-Hodgkin's, but there's small lymphocytic lymphoma. There is, let's see what else is there, diffuse B-cell, Burkitt's lymphoma, lymphoblastic lymphoma. So while most of them are B and T cells, some can be T cell, no, most are B cell, some can be T cell or natural killer cell. Looking to see, yeah, now let me just talk just a little bit more. So there are, like many leukemias, and I didn't put it on here, I maybe should have, non-Hodgkin's lymphoma can be classified in a way similar to acute and chronic. And so in lymphomas, they call them indolent, indolent, indolent lymphomas. And those are just kind of those classically slow-growing lymphomas. They don't always get treated because they're so slow growing that they'll wait until they see some movement, that they may develop into something else. Follicular is an indolent kind of lymphoma, if you were looking. And then aggressive lymphomas are kind of those acute ones. They grow and spread really quickly. They got to get treated right away. The large B cell lymphoma, the diffuse large B cell lymphoma, is one of the aggressive types of lymphomas. Some lymphomas don't really fit into either one of those categories. Mantle cell is one of those. It's not necessarily pegged as either indolent or aggressive. But really, regardless of how they grow, all of these non-Hodgkin's lymphomas really can spread to other parts of the body and kind of wreak havoc. So we have to be concerned. We need to know what they are, and we need to be monitoring them. Even if they don't treat them right away, you got to be monitoring them in case, that we can watch where they're going. So those are our 2 lymphomas that we're going to look at. So we looked at 2 kinds of lymphomas, Hodgkin's and non-Hodgkin's lymphomas. We looked at a couple of different kinds of leukemias, and now we're going to look at some of the plasma cell dyscrasias. These are things that people, I think, necessarily don't always spend a lot of time on. Plasma cell dyscrasias are disorders involving abnormal proliferation of plasma cells. So that's going to be a symptom that we see in each one of these diseases that we're looking at today. Sometimes you might hear them called monoclonal gammopathies. So we're looking at monoclonal immunoglobulin production in these dyscrasias. They are characterized by a clone of identical plasma cells. So remember, when we have mutations of cells, those cell lines can live on by cloning themselves. So they're just going to divide and clone, clone and clone and clone, divide and divide and divide, and we end up with identical plasma cells that all have this malignant characteristic. And so there, again, the plasma cell dyscrasias are characterized by cloning of identical plasma cells and by, as I said, overproduction of a single immunoglobulin component. We call that either the myeloma protein or the M protein, and in some cases a paraprotein. And we're going to look at those and how they're used. That M protein, technically they're all sort of interchangeable words for the M protein. I think you'll see M protein is the term that's used most frequently, but I wanted to associate it back to myeloma protein so that you would remember what that M protein stood for. Let's see, what else? Identification and classification of plasma cell dyscrasias is going to be based on the presence of M protein and then some, and really importantly, some of the clinical presentation that we see, including is there damage to tissue and organs. Not all plasma cell dyscrasias do damage tissues and organs at the same period of time. Eventually they will. What ends up happening is that the M proteins that we see, they're produced in such great numbers that they can damage tissue and organs in a couple of different ways. The M proteins can deposit in the organs and tissues. So we know what happens when we deposit things like immunoglobulins in tissues. It ends up destroying the tissue and damaging it, damaging or destroying tissues and organs. So we end up definitely seeing damage to those types of tissues. The other thing that can happen that can cause tissue damage is that M proteins have the ability to function as an autoantibody. So if things weren't bad enough, they can complex to host cells and destroy the cells that way. So this damage to tissue and organs, we're going to see this repeatedly throughout the plasma cell dyscrasias. Early in the disease, you may not see it, but sort of the end product at some point during diagnosis, you're going to see damage. It may not be, fatal damage, but there'll be definite damage to different tissues and organs of the body. And again, that's by two different mechanisms, either deposition of immunoglobulin within the organs and tissues or the autoantibody, the function of M protein as an autoantibody. Let's see. Some of the plasma cell dyscrasias that we're going to look at are the monoclonal gammopathy of undetermined significance, or MGUS, multiple myeloma, Waldenstrom's macroglobulinemia, heavy chain diseases, and I think we have a few others cracking around in here as well. So let's look at MGUS first. MGUS is a pre-malignant condition. I think 3 to 4% of the people over the age of 50 is a pretty prevalent disease. It's not exceptional, but it's, 4% of the population is nothing to sneeze about. It's diagnostically categorized as having a production of a monoclonal immunoglobulin that is low in serum concentration, less than 3 grams per deciliter. We're going to see that concentration of immunoglobulins is going to be important in aiding in the diagnosis of what kind of plasma cell dyscrasia we're looking at. And also not a huge number of bone marrow plasma cells, less than 10%. Again, that's going to be another important characteristic that distinguishes MGUS from other plasma cell dyscrasias. We're not going to see, this isn't going to be confused with multiple myeloma. The clinical features are not the same. What other findings do we see though? In MGUS, we have increased calcium, so we're going to see increased calcium, and this is going to be a result of, did I say what it is? I didn't. So let me go through the other clinical findings first. So increased calcium, renal failure. Remember, we just talked about the organ and tissue damage, right? Patients tend to be anemic. and we have what are called lytic bone lesions. So what we're going to see some of these M proteins do are going to be very similar to what we saw in patients with rheumatoid arthritis, in that the within the bone, the osteoclast activity is increased and the osteoblast activity is decreased, leading to breaking down of the bones and getting these bone lesions. And what do you think happens when we break down the bones? The calcium is released, right? The calcium gets released into the blood and we end up with an increased calcium value. So MGUS is said to have other clinical findings related to CRAB: calcium, renal, anemic, and bone lesions. CRAB features. It's just a little way to remember it. About 1% of the patients with MGUS will eventually progress to multiple myeloma. And the type of monoclonal immunoglobulin that gets produced is going to give us an indicator of whether those patients will tend to be the ones that develop multiple myeloma. So if the mutation of the patient, again, it's not specific what the mutation causes. So if the mutation causes either an IgG or an IgA monoclonal production, they tend to progress to multiple myeloma. Patients that develop IgM monoclonals progress to Waldenstrom's, and patients that develop monoclonal light chains only develop a couple of things: multiple myeloma, and they also call it amyloidosis, which is another deposition disease. So we're going to deposit amyloid proteins in different tissues, and other light chain deposition disease, where we have excess light chains and they go someplace, they end up getting deposited in tissues. So that's the MGUS disease in sort of a really broad overview. It's it's a good entree into the plasma cell dyscrasias. We're going to see a lot of overlap from these. You may want to make a table of these. It's up to you. They're sometimes difficult to track along with. Multiple myeloma is a malignancy of mature plasma cells, which progressively replace normal normal hematopoietic cells in the bone marrow. So what do we end up with? We end up with that pancytopenia: anemia, thrombocytopenia, and neutropenia. They are the plasma cells. In this case, unlike MGUS, the plasma cells make up more than 10% of the bone marrow. We're also going to see increased M protein, not just in tissues or elsewhere. We're going to see it actually increased in the blood. And the cells of multiple myeloma are CD38, 56, and 138 positive. Let's see. They are also, it's not on here, but a very few number of them, maybe 20% of multiple myeloma patients, also have CD20 positive cells. So it's not a common finding to have CD20 expressed on the cells of patients with multiple myeloma, but it can happen. Let's see. Multiple myeloma also produces these lytic bone lesions that I just described in MGUS, and also that same hypercalcemia. So what we see is mature plasma cells, a predominance of mature plasma cells. So you see these with the eccentric nucleus. Some of them have the nice perinuclear half, the clock face nucleus, the typical that deep blue cytoplasm. And did I say eccentric nucleus? I think I did. And this picture that was from your textbook, which I think the picture in the textbook is just a little bit better, and they also showed one of the long bones, but I couldn't get that on its own slide. You can see the lesions here where you're starting to we're breaking down the bone. You can see the lesions of the bone here. So that's releasing the calcium out into the blood. Let's see. When patients have multiple myeloma, I think, oh, good, I do have it. Do I? No. So let's remember. The monoclonal antibody associated with multiple myeloma is IgG. That's the most prevalent. It's followed then by IgA and light chain only production. So, am I sure I didn't have this? No, it really isn't there. Okay, let me clarify this, just because I thought I had a slide on this and I don't. The monoclonal antibodies associated with multiple myeloma, prevalently IgG, secondary IgA, third, tertiary, I guess, are light chains only. So the ones that are the light chains, this is where we start to see a crossback to urinalysis. When the light chains are when they're found in blood, we call them light chains. When they're found in the urine, I don't know if you remember this, we call them Bence-Jones proteins. And so it's those Bence-Jones proteins that we get them depositing in the kidney, and we end up with renal failure. So I think if we look back at, oh, we did put it, there it goes. We talked about renal failure here. Oh, nope, that's monoclonal. Never mind. In my head, I really did this. Anyways, Bence-Jones proteins are found in the urine, and it ends up causing renal failure from a deposit of those. Other clinical findings that we can expect to see in patients with multiple myeloma, sometimes they end up with some coagulopathies. The high level of monoclonal proteins ends up producing this really viscous blood, hyperviscous blood that interferes with those, if you remember, those inactive circulating coagulation factors. So they interfere with the coagulation factors, leading to things like bruising and purpura, those little tiny microhemorrhages. So abnormal coagulation findings is associated with multiple myeloma. Rouleau formation, that super high level of proteins. If you remember, they cause the red blood cells to sort of stack together like coins, like this. So we're going to see rouleau formation. And there's a really sweet looking plasma cell there. We talked about why we get hypercalcemia because of the lytic bone disease. And we talked about why we get acute or chronic renal failure, which is that deposition of Bence-Jones proteins. And so to be very, very clear, the diagnostic tools that we use to diagnose multiple myeloma, the criteria include plasma cells over 10%, evidence of some organ damage from whether it's in the kidney or elsewhere, based on that deposition of the very, very high amount of serum M protein. That M protein, remember we talked about in MGUS, it was less than 3 grams per deciliter. In multiple myeloma, it's over 3 grams per deciliter. We have that same hypercalcemia. And remember, we call the urine M protein in patients with multiple myeloma. When M protein is in urine, it's the Bence-Jones. And that should be greater than or equal to, that should be over 1. 200 milligrams per day is found in the urine, and they actually do it with a 24-hour urine test. So that's going to be how they are diagnosing that. The next disease of the plasma cell dyscrasias that we're going to look at are Waldenstrom's macroglobulinemia. macroglobulinemia. Waldenstrom's is a malignant proliferation of IgM-producing B cells or plasma cells that can infiltrate the bone marrow, spleen, and lymph nodes. It's also known, you may see it also called lymphoplasmacytic lymphoma. I think most people call it Waldenstrom's, but it's a rare disease. It, maybe 1,500 new cases a year, so it's pretty rare. It's found in, again, older males. Usually the median age is around 70. So there's a fair number of people that are in the 70 plus range. Some obviously younger, but median is 70, so it tends to skew higher. This is another case of family clustering, that sort of, genetic component. But again, when we talked about this family clustering phenomenon, is it genetics or is it epigenetics? Is it that people were exposed to something and as a family, and it caused a genetic mutation? So a lot more needs to be studied about family clustering of disease. So it's one of those, which came first, chicken or the egg kind of thing. But patients, we saw earlier that in patients with MGUS that they can develop Waldenstrom's, and that Waldenstrom's is a B cell or plasma cell malignancy that is demonstrating CD19, 20, 22, and 79A positive cells, antigenicity. So the phenotyping includes those CD markers. Waldenstrom's has kind of, these are not atypical for most of these diseases. Fatigue, anemia. Well, you know what? If you're anemic, you're going to be fatigued. If you're anemic. So those two go hand in hand. Bleeding, plasma because we just talked about the coagulopathy associated with hyperviscosity. So when we have hyperviscosity, we're going to suspect that there could be some bleeding disorders, whether there's thrombocytopenia or not, because of the impaired coagulation process, and also some peripheral neuropathy is associated with it. Waldenstrom's is, as I said, it's a, oops, yeah, no, I'm good. It's, as I said, it's a B cell or a plasma cell disorder. In this case, tumor in 100% of the patients will infiltrate the bone marrow, and to a lesser degree, the spleen and lymph nodes. Unlike other diseases, we see normal to increased lymphocytes, and they tend to be small lymphs, small, normalish looking lymphs. Plasmacytoid lymphs, meaning they're not plasma cells, but they take on the appearance of plasma cells, or even mature appearing plasma cells, not necessarily functioning. So we're going to see some anemia, accounting for that fatigue, and normal platelets and normal neutrophils in Waldenstrom's. As I said, the monoclonal IgM. Oh no, I didn't say this. I said the Bench-Jones and the Bench-Jones protein in the urine is seen. The M protein in urine is called Bench-Jones, seen in only about 10% of the cases, but we can sometimes see a fairly decent. If patients with Waldenstrom's, if their genetic mutation has them producing monoclonal IgM, so the antibody that's being produced by these dysplastic B cells or plasma cells are producing IgM. IgM, if we remember, that can act as a cryoglobulin in patients. So about 20% of the patients demonstrate some cold agglutinins or cryoglobulins. And remember that the problem with that is that when the patient is in the cold, those kind of extremities, the IgM molecules, aggregate together in the small blood vessels and capillaries out in the extremities. It occludes the small blood vessels and causes damage to the tissue there. The hypoxia that occurs, as well as the damage from the kind of the complexing there. So you end up with that cold agglutinin. You come in, you warm up, they dissociate again. Let's see. So it can, in this case also, you can end up with an autoimmune hemolytic anemia. We talked about kind of the M protein as being this autoantibody, having this autoantibody kind of a process. So in this case, it can result in some autoimmune disease. Let's see. One other thing. Frequently, though, in Waldenstrom's, for a period of time, the M protein, the paraprotein, is pretty asymptomatic. So you don't necessarily know about Waldenstrom's right away. It can, it's kind of one of those sort of insidious onsets until the protein levels have developed to significant quantity, and then you start to see damage. Heavy chain diseases, we're going to move on to. We're starting to get into, more and more rare. So heavy chain diseases are another rare B-cell lymphoma. And in this case, heavy chain diseases, you can imagine, are the production of free monoclonal heavy chains. The genetic mutations in the B cells results in a production of abnormal heavy chains that are caused by genetic deletion. So it's not a rearrangement, for example, it's a genetic deletion is the mutation. And because so you're producing all these heavy chains, but they're not normal. So they're incapable of binding to light chains. So you're not developing good immunoglobulins with the production of these heavy chains. Heavy chain diseases get categorized or classified by the type of heavy chain that actually gets produced. So if you're producing alpha heavy chains, this is the most common type, seen mostly in the Mediterranean region, and it ends up manifesting as a lymphoma that involves the MALT, the mucosal associated lymph tissue. That's the GI, respiratory, lymphomatosis forms. The heavy chains disease is associated with the production of gamma heavy chain. Are more localized forms. They're really limited to things like, shouldn't say N equals bone marrow, should be limited to bone marrow or areas outside of the lymph nodes. Things like, oh my gosh, look at this. Look at that. That should be over in parentheses. Like the skin. I'm such a good typist, I'm sorry. And the mu chain disease is extremely rare, and patients have a malignancy that tends to end up resembling CLL. This is a really heavy one, really rare heavy chain disease. So we've already got a rare heavy chain diseases are already a rare B-cell lymphoma, and mu heavy chains are extremely rare. So they end up with a malignancy that looks an awful lot like CLL. So question 3. What non-specific lab test typically demonstrates an abnormally elevated result in all of the plasma cell dyscrasias? I think that if you think back to hematology, you're going to remember that when we're thinking of SED rates, all of those plasma cell dyscrasias are one of the things that we see as a reason for an elevated SED rate. All of those immunoglobulins that are produced with the high number of plasma cells that are in the bone marrow, very high number of high level of plasma cells are being produced in the bone marrow, and then they are being cloned as malignant cells. So we end up with a very high number of plasma cells, and resulting in a lot of these immunoglobulin productions, and they result in increased SED rates. So my clue for the day was SED rate for question 3. So what does this mean to the lab? Laboratory evaluation of immunoproliferative diseases. How do we do it? You know, in the immunoproliferative disorders, it's first informed by medical history and, oh my gosh, look at that. I know how to spell symptoms with an S. Good gravy. Clinical symptoms. Gravy. They're informed by medical history and clinical symptoms. They are identified once the physician has taken a medical history. They see the symptoms, which I just, honest to God, have to fix because I think my head is going to pop off looking at that. Sorry. There we go. Once the physician has really taken the strong clinical symptoms, looked at the medical history, looked at the family history, they're going to work to identify the malignant cell population. We start off simple. We go with a CBC, we go with a diff, we go with some cytochemical stains. We're going to be able to identify, is it a disease with pancytopenia or not, pancytopenia or anemia, some combination of changes within the bone marrow. Then we're going to be able to look at things like the cell lineage by either looking at the differentials. Remember, go by the company it keeps. We can do it by cytochemical staining, those myeloperoxidase kind of stains, for example. Or we can even do some flow cytometry, immunophenotyping by flow cytometry. Again, we're going to try and make conscious decisions about what tests we're doing. We're not going to just order this, kind of random battery. They're going to do a bone marrow. They're going to look and see what the bone marrow looks like. Once they get a sense of the malignant cell population, they're going to drill down even deeper, see what kind of immunoglobulins are being produced and at what level. Remember, we looked at some of them. Their levels in the blood, were they greater or less than 3 grams per deciliter? Were there light chains in the urine? So we're going to evaluate the immunoglobulin status. We're going to look at the serum immunoglobulins. We're going to look at protein electrophoresis to see how, if we're producing monoclonal immunoglobulin populations. We may do IFE in both serum and urine. We're going to do something called immunosubtraction. And then we can look at some free light chain analyses as well. We might do some cytogenetics or molecular testing to assess the gene and chromosomal abnormalities of the patient. So let's take a look at these really quickly. We're not going to spend a lot of time on most of these things because we've done these already, but just as sort of a reminder, flow cytometry is by immunophenotyping is done by flow cytometry. You can go back and look at chapter 13. What do? We're analyzing cell surface markers to see what gets expressed on the cell surface. What happens? We incubate samples with patient samples with panels of fluorescently labeled antibody that are specific for the cell surface markers we're interested in. So if we were looking at patient with multiple myeloma, we were looking for that, CD38, CD56, CD138 to see if the patient has those cell surface markers that would indicate, their presence would indicate, the patient should be further evaluated for multiple myeloma, and in fact, it would be pretty diagnostic at that point, to tell you the truth. Let's see, so we're going to be able to, by immunophenotyping, identify the lineage of the malignant cell population. Remember, abnormalities can be present. It can be either the gain or the loss or the expression of the antigen. And in fact, when you look at some of the tables on chapter 13 and look at the tables, the abbreviated tables in chapter 18, I again made a note, it's on 316, 317 in chapter 18. They're going to give you a good sense of the immunophenotypical markers and the disease that is associated with it. But remember, when we're looking up, especially in the chapter 13, those are the normal cell markers. When we're talking about immunoproliferative diseases, we may be looking at the gain or the loss of an antigen. So the cells that we're looking for and we're looking at in these immunoproliferative diseases are mutated versions of cells. So those cell markers that we look on in chapter 13 may not really be relevant to some of the disease states we're looking here. You can look at, though, they have a column on each of the cell markers that kind of gives a hint if they are involved in some of these leukemias and lymphomas that we're discussing today. That's just a good exercise just to look at them and kind of refamiliarize yourself with them and to understand kind of the value of flow cytometry. You may also recall serum protein electrophoresis is a test where the technique is going to be the technique that we're going to use to identify if there's a monoclonal immunoglobulin. Serum proteins are going to get separated by size and charge into 5 different regions in the electrophoresis. If you look on the top, here's a normal. There are 5 different regions. The gamma, the beta, the alpha 1, alpha 2, and then albumin. So this is kind of a normal 5-region migration pattern. IgM, IgG, IgM, IgD, and IgE also all migrate into the gamma globulin region here. So most of the immunoglobulins are going to migrate into the gamma globulin region, which makes sense. But the monoclonal antibodies, we're going to see that they're going to look different. So this is, this is a typical polyclonal gammopathy. So this is not one of these diseases, but it's one where you have just a production of non-malignant immunoglobulins. So it's those polyclonal, when we're talking about polyclonal immunoglobulins, we're talking about heterogeneous populations. So they get derived from clones of plasma cells, but not necessarily these mutated versions that were only producing monoclonal gammopathies. So if we look at kind of the pattern in the polyclonal, do you see how we have these really broad peaks versus, these really sharp peaks of a monoclonal gammopathy. It's because monoclonal it's a homogeneous population, so it's really going to be a narrow peak, and it's not going to have this. It's not going to include a whole bunch in the gamma region, for example. It's going to produce just a single peak. So monoclonal immunoglobulins actually don't move that far because, again, they're just one specific type of immunoglobulin. It's not a combination. Remember, this band was IgM, IgD, IgE, IgG, versus this, we're just looking at a single monoclonal antibody, whatever the patient is producing. Could be, it could be an IgM, we can pretend what it is. So the tall, narrow peak in the gamma region of the patient that we suspect of having one of these diseases is representing, this monoclonal antibody, this one sharp peak. We should also remember that when we look at the underneath here and we look at the staining that is represented by this graphic, the really dark stains here represent a relative concentration. So if you were looking at whatever's in this area, you have a stronger concentration than you do out in this area. So It's showing an intensity, and it's showing that there's not a lot of variation of the concentration at that particular area. So that's kind of the basics of serum protein electrophoresis. We'll do more of this in chemistry, no doubt. Immunofixation electrophoresis, again, we've spoken about it briefly, or not so briefly. We can remember that IFE is really sensitive and really specific. And in this test, serum is electrophoresed in one of 6 lanes. 1, 2, 3, 4, 5, 6 lanes. And so we're going to freeze the serum, the patient's serum, in an agarose gel, and then we're going to apply in individual lanes. We're going to apply specific antisera. So here we're going to apply anti-G antiserum, anti-A, anti-M, anti-Cal. So these are the light chains: anti-Cal, kappa, Cal, kappa, and lambda. I'm getting my blood banking in there. Just rolls off your tongue when you're talking about it. Anti-kappa and anti-lambda. And so where you see that complex take place, so if the patient has, we applied this patient the serum well, they're electrophoresed, so the sample electrophoresis in this direction, and where it binds into the, and the anti-A is all the way across this whole thing. So where the anti-A and the lambda binds to the lambda in the patient's serum, where they complex, you get a band that is stained, and we can read it, and we can see, we can detect if there are, what kind of chains there are, and you can detect the presence or absence of monoclonal or polyclonal antibodies here. So this is, again, we're going to visualize them in a pattern much like this, just with a stain, and then they kind of do a denaturing step afterwards just to get rid of the background noise that's associated with it. So let's take a look at a normal versus a monoclonal immunoglobulin. Remember, on lane 1 is it's a whole human serum, and this patient has a normal polyclonal bands. You can see they're very diffuse. They're very, the IgG, look how broad it is, right? Very diffuse. These are not, really sharp bands, versus those of a monoclonal. You can see they have incredibly sharp bands. So this patient has an IgG and an IgA, an IgG with a lambda light chain. IgG so it has gamma heavy chains with lambda light chains as a monoclonal antibody. So we can see that those discrete bands are found in those 2 lanes, and we've identified what the monoclonal immunoglobulin that's produced in this patient is. This patient could very well represent, a patient with multiple myeloma, for example. So when you have these large diffuse bands like this, that indicates they're polyclonal. Remember, it's a heterogeneous population, so we're getting variation in the production of antibodies. They're not coming from a malignant clone that you're just producing the exact same thing. These are production of clones, plasma cell clones, mutated clones, so they're producing exactly the same immunoglobulin over and over and over again, and that's why you get those really narrow and sharp bands. The process of immunosubtraction is an interesting one. It's a technique that uses what's called capillary electrophoresis, and we're going to use it to identify monoclonal antibodies. This is more sensitive variation of immunofixation electrophoresis. And we're going to see in a second an example of this. The way the test is done, antisera is added to the patient's serum. If the antisera that we added will bind to the patient's monoclonal immunoglobulin, it's going to change the electrophoretic mobility, and we're going to actually see the monoclonal peak disappear. So let's look. Again, technique uses capillary electrophoresis to identify it. So we're going to add antisera to every heavy or light chain isotype that's available, and that gets added to the patient's serum. So when whatever it is that we're looking at, IgG and IgM with a kappa light chain, whatever it is, whatever we're binding the antisera to within the patient's serum, if we look here, this represents, this peak right here represented the electrophoresis without the immunosubtraction in it. And so we see a really sharp peak in the gamma region here. And when we add antisera, we do it a second time, and do you see how we lose that peak? What happened is we bound off. Let's say this was IgG. I don't know what it was. I don't have the key in front of me. Oh, well, it was. Let's see. This one is IgG, right? Oh, this was kappa. That's why. So this was a kappa chain. So this had an anti-kappa chain here. So this patient had a monoclonal antibody that one of the things that was produced by their malignant plasma cells were kappa chains. And you see this reflected here. We added anti-kappa to the patient's serum, and they bind off together. It's a typical antibody-antigen reaction. It's going to slow down the electrophoresis, and you don't get this sharp peak anymore. You end up with very large complexes that are obviously going to change the electrophoretic pattern altogether. So we subtracted, when we know that this represents the kappa, we subtracted this monoclonal peak. So we're actually looking for identification or immunotyping by having the disappearance of the monoclonal peak. Similarly, this was a patient that had a monoclonal IgG, and we saw it right here, right? Then we added anti-IgG, and the peak disappeared. So we deleted this peak when we bound it off to the antisera. So we bound the patient's monoclonal immunoglobulin component, bound to the antiserum, the reagent, and we deleted, or we lost this peak. This is the albumin peak, and you see we didn't really lose the peak here. That's because this is always a very large, narrow peak here. So that doesn't represent a monoclonal antibody. This one did. You saw a difference here. If there was anything in this region, we'd see it, a little small blip here. We would have deleted this peak, but we didn't because it wasn't there. And everything else pretty much follows along with the original electrophoretic pattern. You do see some differences because we've created these new components, right? This new bound antisera patient monoclonal antibody component that is still going to travel. Does that make sense? Immunosubtraction. Let me know when we meet next time if you have any questions about it. Serum-free light chain analysis, or FLCs, are really briefly, it's a really sensitive quantitative assay that is a little subjective. It is going to measure free kappa and lambda light chain concentrations in serum, and we're not going to go over the process for it because it's not really the point of this discussion. This discussion is reminding us that in the serum-free light chain analysis, what we do is we're going to calculate the ratio of kappa chains to lambda chains. And the normal ratio is anywhere between 0.26 to 1.65. If in our calculations we see an abnormal ratio and an increase of either kappa or lambda, it's indicative of a plasma cell dyscrasia and the production of these abnormal kappa and lambda chain by the plasma cell clone. So we're going to measure both the free kappa and lambda light chains, and then we're going to compare them comparatively, the concentration one to another in normal serum. We're right at the end. Cytogenetics is, we talked about this last week. Cytogenetics is just a traditional karyotyping, and FISH is another mechanism for cytogenetics, fluorescence in situ hybridization techniques, where we can identify some chromosomal abnormalities. FISH is, we're going to fluorescently tag probes to bind to the complementary DNA strands of the sequences. And we're going to use, as you may recall, we're going to use interphase cells that get hybridized with that molecular probe, that complementary molecular probe. And if we look at this example, in this case, they did this for to look at the chromosome 9 and 22 translocations of a patient with CML. So if we look at the figure on the left is a patient that has a normal cytogenetic chromosome pattern for chromosomes 9 and 22, and the patient on the right represents someone who has a translocation. And so if we look at the green, so here's the green on a normal patient, and here's the green here, and there's a little bit bound in here with the yellow. That represents the BCR gene on chromosome 22. The red is the ABL1 gene on chromosome 9. And the yellow that develops, see there's no yellow in here, this is that translocation of the fusion of the BCR ABL. And so they fused, and we see a difference. So that you see a little red, you see a little green, but now you see something fluorescing differently. It's fluorescing yellow because we have that specific probe there that's caused by that genetic rearrangement. So you can see they can read, and you can see it's, it's quite specific in how it can be read. And I think that this is one of those things that requires an incredibly large degree of training to do this. But it's important to understand briefly. And then finally, finally, molecular testing. We know an awful lot about this at this point. So molecular testing is obviously more sensitive than cytogenetics, which are, clearly subject to interpretive analysis. And this, we're going to use molecular testing to look at some of those genetic mutations. Are they microdeletions? Are they clonal rearrangements? What's going on? So are they clonal rearrangements for B or T cell malignancies? So if we look at the illustration in your book, this is we're going to be looking at the VDJ region, the variable region of the immunoglobulin heavy chain. So that's specifically what we're looking for. We're looking to see if this patient has a variant in the heavy chain. If we look in, so they're going to go through an amplification process. They're going to measure it. There's the product, and then we're going to see them on a gel. And so if you look at lanes 3, 6, 9, and 10. 3, 6, 9, and 10 are the malignancies of, as the DNA of the malignant cells. And you can see, again, those super sharp 3, 6, 9, and 10. You see those super sharp lines? And what do we know that those represent? Those represent the monoclonal antibodies. 4, 8, and 11 are patients with kind of a normal, broad, polyclonal antibody production, kind of that smeared band, broad band, or smeared band. And we get that smear because of that diversity among the VDJ arrangements that take place from the genetic inheritance of them and the expression of them. Whereas monoclonal antibodies, we know they only produce one product. There's a malignant cell, and they just clone and clone and clone the cell to So we end up with only a very high production of one particular. Doesn't mean there's not other cells that are normal that are still producing, but it's the malignant cells that are producing these monoclonal spots here. And so that's really how we're looking at this. Then we can interpret the migration pattern of these samples to identify the monoclonal the monoclonal immunoglobulin product of those mutated cells. I hope this makes sense. Go through the summary. A lot of times that gives you a hint of where we're going and what we should be doing. There's the references, and I will talk to you soon. Let me know if you have any questions. I did put up a chapter 17 study tool practice quiz for you guys. So hopefully that will help as well. Thanks so much, and I will talk to you soon. Let me know if you have any questions. Bye-bye.